Well, that's a nice segue into talking about therapy and induction therapy. And Rachel, maybe you can start us off and talk about kind of what the optimal approach to induction therapy is for ALL and what factors you take into account in your treatment planning.
Right, and I suspect that our induction therapy may be different than many adult regimens, but in general for pediatrics, we employ a standard induction therapy which consists of either vincristine, pegosparaginase, IT methotrexate, and steroids, either prednisone or dexamethasone, plus or minus anthracycline. And for the Children's Oncology Group, we reserve the anthracycline use in induction for patients with NCI high-risk disease and infants because we know they are harder to get to an MRD negative remission at the end of that month of induction. Additionally, we know that patients with increased leukemic burden in their CSF at diagnosis require additional CNS-directed therapy, so we administer extra IT treatments throughout induction to clear that the CSF disease.
Mm-hmm. Okay. Ryan, what have we learned from our pediatric colleagues about how to treat some of our younger patients with ALL?
A lot, in my opinion. So while I think there still is certainly some healthy and appropriate controversy on this topic, I think many of us that treat adult ALL have transitioned towards using pediatric-inspired regimens for young adults. The age range that we use to define that is a bit of a moving target. Again, as an adult oncologist where I see primarily patients above 18, I typically think of young adult ALL as being under 40. The C10403 intergroup study that was just published this year, that was the upper age range that they used in their trial, a regimen modeled virtually identically off of a high-risk pediatric ALL regimen. And I think that the results from that study were certainly encouraging, and many have taken that on as a standard approach for pH-negative young adult ALL.
Yeah, I think what we've learned from our pediatric colleagues is that they use much more of the non-myelosuppressive drugs that I talk about, vincristine, pegosparaginase, steroids, and I think we've incorporated that into some of these young adult regimens. And I think there's a lot of factors that can play into the outcomes of these patients, but I think the use of those agents in higher doses and more intensively has been a big difference in that category.
I would add, though, they are not for the faint of heart in terms of administering these treatments. There's a pretty steep learning curve to learn how to administer these regimens safely and effectively. So it's definitely something to make sure that you feel comfortable with before embarking upon such a treatment.
Yeah, and a 35-year-old is still not a 10-year-old, and there's more toxicity. It's certainly been my experience as well. Rachel, could you talk a little bit about the Philadelphia-like ALL and what you and your pediatric colleagues are, how you're addressing that?
Yeah, I think it's an exciting area where we could really move the needle for some patients. Certainly we're hoping in the same way we've done with pH-positive patients with imatinib or dasatinib. So we're studying this in the Children's Oncology Group, and other consortiums around the world are also asking the same questions. And so we have an arm of our past NCI high-risk trial where they're incorporating dasatinib for the ABL class fusions that are identified as pH-like. Additionally, we have another trial run by Saratazian. It's an industry-sponsored trial with Insight where they're using ruxolitinib for patients with JAK activating pH-like lesions. We don't yet know if this will really improve outcomes. Step one was to determine if it was tolerable to do. We were quite confident that the introduction of imatinib or dasatinib for the ABL class fusions would be tolerated as it was in our pH-positive patients, but ruxolitinib was sort of an unknown. It had never been incorporated into the intensive chemotherapy backbone that we give our pediatric patients. Thus far, that trial has shown that it is tolerable.
Do you think it's actually a little too late to be added by the consolidation? Because most of these pH-like patients will be MRD positive at the end of induction 1 and 2. So do you think we can actually get there too late?
It's an excellent question, and I think incorporating imatinib or dasatinib during induction by day 14 certainly has shown to be tolerated and probably more effective at clearing that MRD in our pH positive. So ultimately that may be the goal, to move that into upfront therapy. But again, we were in really early stages of incorporating ruxolitinib into our chemo backbone. So I think starting post-induction made a lot of sense for the study design. Mm-hmm.